Alright, welcome to this explainer. Today we're going to translate the incredibly complex, invisible forces of the fetal to neonatal cardiovascular transition into real, actionable clinical knowledge. For those of you actually managing patients in the delivery room, understanding the sheer mechanical and biochemical shifts that occur at the exact moment of birth, well, it isn't just academic. It's literally the foundation of every single resuscitation guideline you follow. So let's dive right in.
To master this transition, here is our roadmap. We'll briefly cover fetal circulation pathophysiology, the hemodynamics of the first breath, mechanisms of shunt closure, the AHA 2020 resuscitation guidelines, and finally, clinical implications and defects.
Starting off with Section 1, Fetal Circulation Pathophysiology. Let's establish our baseline and look at this highly specialized, perfectly adapted fetal environment. Now, birth represents this instantaneous stark shift from a parallel circuit dominated by the placenta to a series circuit that is totally reliant on the lungs. In utero, the lungs are fluid-filled and they aren't involved in gas exchange at all, which creates this massive pulmonary vascular resistance, or PVR. Meanwhile, the placenta is acting like this huge, low-resistance reservoir, which keeps systemic vascular resistance, or SVR, incredibly low. It's basically a complete mirror image of adult physiology.
And when you look at the anatomy, it's honestly brilliant how it accommodates these pressure gradients. Look at the three main shunts here. Oxygenated blood from the placenta enters the umbilical vein. And because of the porta-caval gradient, this highly oxygenated blood accelerates right through the ductus venosus. It bypasses the liver and preferentially streams directly across the right atrium through the foramen ovale and straight into the left side of the heart to supply the brain and the myocardium. Meanwhile, the deoxygenated blood coming down from the superior vena cava hits the right ventricle, but because PVR is so high, it just bypasses the lungs via the Ductus Arteriosus, dumping directly into the descending aorta. It really is a masterful parallel distribution system.
But because the fetus is operating in this parallel circuit, the oxygen saturation naturally drops to an intrapartum mean of about 40 to 50%. Keep this totally counterintuitive physiological norm in mind. It is entirely normal for a healthy newborn to appear cyanotic in those first few minutes after birth. Their baseline is effectively hypoxemic compared to an adult. Moving right along to Section 2. Hemodynamics of the first breath. The moment the umbilical cord is clamped and that newborn inhales, a massive cascade of hemodynamic triggers is initiated. There is a quote that says, "The most deadly day of anyone's life is the day they are born." It sounds dramatic, but it's absolutely true. As this illustrates, the physiological changes triggered by that very first breath are drastic and entirely critical for life outside the womb. If this transition fails, the consequences are immediate.
So what actually happens? When the newborn takes that crucial first breath, the alveoli mechanically expand, physically forcing fetal lung fluid into the interstitium. This physical expansion alone causes a drop in PVR. But biochemically, as oxygen rushes in, hypoxic pulmonary vasoconstriction is instantly abolished. On top of that, the sudden rush of pulmonary blood flow creates shear stress on the endothelium. This upregulates eNOS, endothelial nitric oxide synthase, releasing nitric oxide, which is a potent vasodilator. The end result? A massive, immediate drop in PVR, which finally allows the right ventricle to pump blood into the lungs. It's a total game changer.
Now, you've probably seen these Frank-Starling curves before, but these fetal ventricular function curves are vital for your clinical practice. Unlike adults, fetal ventricles are relatively stiff. They operate near the very top of their function curves, meaning their stroke volume is pretty much fixed. The Frank-Starling mechanism has very, very limited capacity here. What this means for us clinically is that a newborn cannot simply increase their stroke volume to improve cardiac output. They rely almost exclusively on heart rate. If that heart rate drops, cardiac output tanks. Plain and simple.
All right, Section 3, Mechanisms of Shunt Closure. With PVR dropping and SVR rapidly rising due to the clamping of the umbilical cord, the pressure gradients completely invert, forcing those fetal shunts to close.
The physical pressure changes literally slam the flap of the foramen ovale shut. But the ductus arteriosus? That requires a chemical trigger. In utero, prostaglandin E2, which is largely derived from the placenta, actively keeps the ductus arteriosus patent. Once placental circulation ceases and arterial oxygen tension rapidly rises with those first breaths, PGE2 levels absolutely plummet. This chemical shift triggers the smooth muscle of the ductus arteriosus to forcefully constrict.
Notice this critical distinction here. It's a classic board exam topic. Functional closure, which is driven by shifting pressures and the drop in prostaglandins, happens in a matter of hours, with 100% functionally closed by 96 hours in healthy term infants. It's basically the door swinging shut. But true anatomical closure, where the vessel actually epithelializes and fibroses into a solid ligament, takes an extended 4 to 6 weeks.
Let's get into Section 4 AHA 2020 Resuscitation Guidelines. This is where we bridge the gap between all this theory and your immediate clinical action.
So ask yourself, how does this specific hemodynamic physiology actually dictate our newborn resuscitation protocols? I promise you, it's not arbitrary. Every single step in the AHA neonatal resuscitation guidelines is explicitly designed to manipulate these exact vascular resistances and support this delicate cardiovascular transition from a parallel to a series circuit.
The 2020 AHA guidelines are built entirely on this transition. We delay cord clamping for at least 30 seconds to allow a placental transfusion. This gives the infant the blood volume needed to adequately perfuse and recruit those newly opening lungs. But most importantly, and if you take nothing else away, remember this. Because the lungs must be mechanically recruited to drop that high PVR, positive pressure ventilation, or PPV, remains the absolute most important intervention in neonatal resuscitation. Without lung expansion, the transition halts entirely.
Applying this directly to the AHA algorithm, if the newborn is apneic or gasping, or if that heart rate falls below 100 beats per minute, we must immediately intervene with PPV within the first 60 seconds. By doing this, we are manually forcing the alveoli open, forcing the fluid out, abolishing the hypoxic vasoconstriction, and manually driving the transition from a parallel to a series circuit so the heart rate, and therefore cardiac output, can rapidly recover.
And because we know the fetal O2 baseline is naturally low, we absolutely do not aggressively use supplemental oxygen to just pink up a baby. Blasting a newborn with 100% oxygen unnecessarily causes severe oxidative stress. As you can see here, it naturally takes a full 10 minutes to reach over 90% saturation. So we use targeted oxygen guided exclusively by a preductal pulse oximeter placed specifically on the right hand so we can measure saturation before any potential ductal admixture.
Wrapping up with Section 5, Clinical Implications and Defects, let's look at what happens when this intricate transition sequence fails or when the anatomy doesn't adapt as it should.
If the shunts fail to close, the newborn suffers from abnormal blood admixture. If the foramen ovale stays patent and right-sided pressures remain high, you get right-to-left shunting. This bypasses the lungs entirely and causes severe hypoxemia. Conversely, a patent ductus arteriosus, or PDA, once SVR rises, will cause oxygenated blood to shunt backward from the high-pressure aorta into the lower-pressure pulmonary artery. This left-to-right shunt literally floods the lungs, causing pulmonary congestion and vastly increasing the workload on the left heart, which can quickly lead to heart failure.
But when the transition is completely successful, the biology elegantly cleans up after itself. Over weeks, these vital fetal lifelines epithelialize into non-functional anatomical ligaments. The foramen ovale seals into the fossa ovalis. The ductus arteriosus fibroses into the ligamentum arteriosum, and the umbilical vein becomes the ligamentum teres. The transition to a fully independent, series postnatal circulation is physically, permanently sealed. Before we wrap up, I want to leave you with this final provocative scenario. Imagine a newborn inhales, but for some reason, perhaps severe meconium aspiration or chronic fetal hypoxia, their enos pathway fails to activate. They simply cannot produce nitric oxide. Pulmonary resistance stays massively high. The right heart cannot pump into the lungs. The shunts stay open. How does this disrupt the entire shift we just mapped out? And based on the AHA guidelines, what must your immediate clinical intervention be to break that cycle? Think deeply about this. Mastering the why behind this transition isn't just about passing your boards. It's the exact logic you're going to need the next time a newborn crashes in your delivery room. Thanks for joining this explainer, and until next time, keep questioning the physiology.
Thank you for watching. Kindly like and subscribe and follow for more such videos.